just so we're clear, I actually work for a Catholic health system, because the keynote speaker mentioned the Catholic Church and other churches as related to health policy, what have you. There is also a pecking order, at least from the church's point of view, who's responsible for making those decisions and whatnot. So I don't want you to come away from this conference thinking that all Catholic churches or Catholic-related healthcare system is bad. That is actually not true. There is one Catholic healthcare entity in this country, but there are several orders and several health systems that are underneath that. So when you hear the Catholic health system, it is not just one health system. There are several health systems, and they are responsible for making their own decision within each of their health system, but ultimately they have to ask for permission from the 33 archbishops and bishops in California who oversee the Catholic Church. So I'll give you an example. If my Catholic health system, Providence St. Joseph Health System, want to make a decision that is considered controversial in terms of how the Bible is being interpreted, as is related to, for this example, would be, the easiest example would be sex reassignment surgery for transgender population. All health systems struggling with that, especially health systems that do take people with Medicaid in California, is Medicare. The reason being, by, at least in California, the benefit in the Medicaid is that sexual reassignment surgery is a benefit. So if you want to have a contract with the Medi-Cal system, then you must provide that benefit. So if you are from a health system that have a religious belief, how do you get around that, right? On the one hand, you're taking money from or you're receiving money from the state to provide a set of benefit. You can't pick and choose, well, I want to do this, and I don't want to do that. There's issue, and the speaker spoke eloquently on how liberal Washington and California have been in terms of the forefront for discrimination, any type of discrimination, not just on sexual orientation. So it become a very interesting conversation. All right, so I'll get more into detail, but please write down my email address. If you like this presentation, if you want a copy of it, just send me an email address. Send me a message to this email, and then I'll forward the PowerPoint presentation to you. As well, if you have any question, that's the best way to get in touch with me. I'll give you my phone, but I really answer phone. So, but this is my niche for my employer, right? The email address. So I'll respond quickly. So I thought what I would do is go through truly what are the insurance, what is the protection under insurance, and particularly pay attention to the Medicaid or Medi-Cal, in this case, California, realm of reality, because when you talk about LGBTQIA plus population, despite popular belief, a lot of people in this community are actually quite poor, and how the effect of the ACA have been to the community in terms of access to health care. And then that's other way for me to do this is to get you interested in participating in providing care for individuals who have this type of insurance. Because believe it or not, even though we have a community of health providers that are culturally inclusive and sensitive to the LGBT, for sure, population, but not many people participate in government insurance just because of the payment system. So that's another piece that I want to talk to you all about in terms of, we can talk all day long about we need to have indiscriminatory policy as related to health, and we can advocate all day long, but at the end of the day, when you and I, or people in our community, needed services, treatment, and we can find someone who take our insurance covers, is a moot point. Do you understand what I'm saying? So we can advocate all day long, and we can get access to everybody as we want, but at the end, a very poor person in our community go seek for a healthcare provider and they couldn't find an LGBT provider. That's still an issue. And that's what's happening right now, is if you're poor and you're on Medi-Cal, it's very difficult to find LGBT providers. And I'll tell you what are some of those services and why that is, okay? And clearly, number one, I want to put it out there for those of you, oh, well, let me do this. How many of us in the audience are medical students? Oh, student in the medical field. Let's make it that way. All right. And who are the rest of you? Provider? Yes?
High school student.
High school, wow, high school student. What kind of outreach you guys are doing, John? That's fantastic. So, aspiring to be a healthcare provider, I hope, right? Perfect. The rest of you?
Pre-med.
Pre-med, okay. Anyone who actually
Healthcare psychology.
Healthcare psychology, yes. Anyone who actually providing services? Very good. Primary care physician?
I work here at UCI for the Gender Diversity Program.
Okay.
I do like the program coordination and
Perfect.
patient care.
Perfect.
I'm an occupational therapist for the County of Los Angeles.
Fantastic. You, sir?
Doctor of Pharmacy, managed care for Medi-Cal.
Fantastic. Okay, so you two know what I'm talking about, right? All right, so
Every day.
let's get to that. All right, before ACA, don't write this down. I'll send you the PowerPoint if you're interested. Just enjoy, and let's have a conversation. Let's have a dialogue, okay? Because if your experience is not the same, I want to hear you, and let's talk about it. Because I've always said that there's always spotlights that nobody's aware of. So if you work for a program or an entity that's truly inclusive, let it be known, let people know. Okay, so please don't be shy to share that. So before ACA, before healthcare inclusion and the expansions of the health services in this country, for poor people, the only way you can qualify for Medicaid or Medi-Cal in this state is very simple. Simple in the sense that different states has different criteria, but basically the only way you could sign up for Medi-Cal is if you are a pregnant woman or poor parents with children or someone on disability, or someone on disability, right? So disability meaning the federal government have to declare that you are totally disabled, and you therefore qualify for Social Security supplement, or Social Security income supplement, or SSI. Other than that, it's very difficult to get on Medi-Cal, right? And so you'll hear story of young adults, single adults, who are very, very poor, but still couldn't get health care because you weren't in a class that would qualify for Medi-Cal. Particularly individual in the LGBT community, and particularly the transgender population, which was the most affected, because imagine you're transgender, you get all of that kind of employment discrimination, so you couldn't work, and you didn't have an income, you couldn't really buy insurance, even if an insurance said, yeah, I'm including everyone in the enrollment, you couldn't afford it, right? So what ACA does, prior to truly 2014, that there was about close to 50 million Americans who were uninsured. Now, this $50 million, this 50 million figure is only accounted for individuals who are legal resident in this country. It did not account for individuals who are not here legally, or that'll better word, undocumented populations. So the number was much higher than that. Okay. So healthcare reform, the keynote speaker spoke to some of that, but here's a little bit history for those of you who did follow healthcare reform. Won't get into the detail of it, but basically it really brought a whole bunch of Americans into the healthcare system. The reason I said brought into the healthcare system and not necessarily give them healthcare, because there's a difference in having a plastic card and then trying to access care. Don't forget that piece. Just because you have health insurance, it doesn't mean that you have access to care. Let me repeat that, because a lot of people miss that point. Just because you have healthcare coverage, it doesn't mean that you can get health services. For our pharmacists, and he knows what I'm talking about, for the people who work for health plan, you know what I'm talking about, right? Because, particularly in a government-funded health system like Medi-Cal and the exchange product, you all familiar with the exchange product? Yeah? Raise your hand if you are.
Medical.
Above Medi-Cal. Okay, so it looked like I need to do a little bit of that. That's great. There's a slide in there that would explain that. Okay, so what happened was, the other piece with ACA was very important. Remember earlier I told you that Medicaid in the country prior to 2014 were very different based on each state. And basically, a simple understanding of how Medicaid works is that the federal government would pay for 50% of the healthcare costs for poor people in the state. So each state would have to cough up 50% of the cost, roughly, in order to cover healthcare for the poor. And so, depends on each state's budget, the state could set what is that cutoff, right? But in 2014, with the advent of ACA, it's the federal government that decides what that cutoff is and how people could qualify for Medicaid across the country. So by that I mean prior to 2014, if you have Medicaid in one state and you move to another state, you might not qualify for Medicaid in that state because it's state dependent in terms of criteria. After 2014, if you qualify for Medicaid in one state, you pretty much qualify for Medicaid in all states because the level of income setting is consistent across the whole country. Okay? So that's what it did. And so pretty sure, it really allowed people who are on Medicaid to be able to move around based on their family need and not having the risk of losing their coverage on Medicaid. There's a huge effect, particularly in California, because as you probably have heard, California and 24 other states in the union decided to expand their Medicaid coverage for what we call the single-childless poor. Single-childless poor people, right? So suddenly, now you see why a whole lot more folks in the LGBT community become eligible for Medicaid, because it's no longer based on the other criteria that I mentioned earlier. So basically, if you're poor, you qualify for Medicaid, period. So it brought in a whole lot more of folks from other cultural community or ethnic community, and it took health plan by surprise because they weren't ready for it. Does that make sense? In fact, the state of California didn't even prepare that if we expand Medicaid, possibly a lot more transgender people would now qualify, and based on ACA, sex reassignment surgery is a benefit that we now have to figure out how to get this surgery to these people. So far so good? The problem is there is no single surgeon who does sexual reassignment surgery contract with the state Medi-Cal system. So that's what I meant by even though you have that benefit, but there's no one to do that or provide that benefit, it's still an issue. So when, number one, number two, people who qualify for Medicaid or Medi-Cal in California didn't even know that that is one of the benefits because nobody talked about it. Not that the health plan didn't want to talk about it, but they didn't know. I can say they because I've been out of the health plan world for a year now, so I can say they. They really didn't know. So when I worked for LGBTQIA Health Plan, one of the largest health plans in the country, non-public, a public health plan in the country, with over 2 million now, right? 2 million membership. And that means that most transgender individual in the county of Los Angeles qualify for Medi-Cal and become our members. We health plan refers to people as members. But the health plan didn't know that they existed because in the demographic information that the state sent to each health plan every month, here are the people who qualify for Medi-Cal. They picked you in county where people have an options, or in county there's only one health plan, Medi-Cal health plan, and here are the people you have to provide services for. Nowhere in that demographic statistic that would tell you whether or not a person is belong to the LGBT community. So the health plan didn't know how to outreach to the individual. And worse than that, people were assigned basically by rotation to different health systems. And the assignment is only based on where you live, where your address is closest to, right? So you can see there are people in, so I believe, there are poor people in West Hollywood, definitely. Just like in Orange County, there are poor people who live in Newport Beach and what have you. But that means that for them, the the provider who participate in that network is probably much less than for other cities, right? Because most likely the physician who practice in those communities are actually cash-paying physician or enroll themselves in a health insurance that pay at a higher rate than for Medi-Cal. So therefore, if you're poor and you live in a city like that, your access to a closer provider is not as great as somebody who live in a poor city where there's a lot more providers who participate in Medi-Cal. All right? Number one. Number two, if you live in a city and you get assigned and the health plan really didn't know what your sexual orientation is or your gender identity is. You knew, oh, I've been assigned to Dr. Chau and he's well known to be really bad practice and not very inclusive. I won't go. And people rarely speak out, or actually because they didn't know that they have the right to contact the health plan and make changes. Now, health plan will say, yes, of course you do. We send you a menu. How thick is that menu? Hundreds of pages. How many of you read every single menu that gets sent to your house? Or do you even go online, read your menu? How many of you actually did read the menu of your insurance company? Please raise your hand. Not even the people who's in medical school? Oh, you do?
I work for a company that's self-insured, and I work with a contracting department.
Wow. Yeah, you have special case. Do that. So you don't know you're right, and you don't. With that, actually, there's two numbers that I will give you, because this will help yourself and your friend in case you want to complain about benefit or being treated inappropriately by any of your providers, including the health plan. So there are two entities in the state of California that regulate insurance, beside the Department of Insurance, which is very slow to respond. I'm sorry. Please don't tell them I say that. They might be upset. But there are two entities that really respond very quickly to your complaint or your question. So the first department is Department of Healthcare Services. And that number is 888-452-8609. Again, 888-452-8609. And the other company, and the Department of Healthcare Services are actually a department that would regulate and make sure that all the benefits is being implemented. They the one that send the money to the health plan to do whatever they need to do. They have a contract with the health plan. The other department is truly an advocacy department, and that's is the Department of Managed Healthcare, right? And that number is 888-466-2219. 888-466-2219. Majority, I would say 90% of the people who work for that company are actually lawyers.
Department of Healthcare.
Yes. So they are majority lawyer, and they handle cases of complaints, right? Sometime before when I worked for the health plan, my message would be, we'll call the health plan, we'll take care of you first, don't go to the state. Now that I no longer work for the health plan, the quickest way to get your complaint resolved, call the state. Okay, please don't go back and tell LGBTQIA that I say that. Because these lawyers at Department of Managed Healthcare want a response from the health plan within 48 hours. And in emergency cases, within a day. Yes?
Yes, there's a case recently that the state is fining HealthNet for terrible services for LGBT patients.
Yes.
And I was so happy to hear that. Like, the state is paying attention. Like, they're really watching what is and isn't happening.
Yeah.
So I think that's extraordinary.
Yes.
Incentivizing good care.
Well, I think the reason the state, especially the Department of Healthcare Services, recognized that was LA Care. Well, we were a group of employees at LA Care who actually brought that attention to the state. So I want to give credit to LA Care. We went to the state and said, did you know that particularly in LA County, we have a lot of folks, members from the LGBT community, and they were assigned inappropriately to provider, or they live in, let's say they live in the Palmdale area. There are just virtually no LGBT provider there, right? How many of you honestly, once you become whatever you become and get licensed, that you really want to move up to Palmdale and open your practice? Not really, right? And so therefore, there are people who live up there actually have no access to the LGBT provider. Now, not to say that there aren't allied providers who are very, very sensitive. In fact, LK Health Plan was the first health plan that had a conference on LGBT health. And to our surprise, very different from this conference. This conference is, just preaching to the choir, what have you. But that conference, we had well over 60% of the provider who came that had no knowledge of how to provide care for the LGBT community. But they wanted to learn because they realized that they got assigned member and they didn't know how to provide the care for. We were really impressed by that. In fact, we had some, I remember I put that conference together, and we had like a dozen primary care physicians who was very mature in their 60 and 70 come up to us and say, thank you so much for putting this together. We learned a whole lot. And we looked at them and we're like, well, why did you decide to come? And they said, well, we realized that we have patients who belong to this community and we didn't know what to do for them, and we want to learn. So there have been effort, and we invite the state to it, and people spoke about it. Providers really, even when they enroll in Medi-Cal, they didn't know that that's a responsibility for them. Health plan didn't know that you're not supposed to ask for prioritization for hormone. And for our pharmacist friend who work for a health plan, there are health plans who still require primary care physician to request for an authorization in order for folks to be on hormone, sex hormone, which is absolutely absurd. We took that away, right? And then even if health plan wanted to pay for a sex reassignment surgery, we had a hard time finding appropriate surgeon, right? Of course, you have to find someone who have experience in providing this kind of procedure. number one, there's a shortage in the country. Many of them are concentrated in California, but up north in the Bay Area. Number two, not many want to sign up to have a contract with Medi-Cal. Really, just because the payment is so low. So I'm not passing judgment, but I'm telling you that's the reality of the case. There are health insurance that would pay a higher rate, or there are people who can afford it and be willing to pay for cash. So the incentive for these providers to sign up or to take Medi-Cal patient really isn't there, because when we compare the pricing, it was pretty depressing. So we at LA Care Health Plan had to go to the state, and thank goodness our CFO was someone who very passionate about the vulnerable population. So we went up to the state and we fought with the state and said, hey, number one, you didn't realize that with the change in the Medi-Cal criteria that you now brought in 7, almost 8 million new people to the Medi-Cal world, and yet many of them belong to the transgender community, and they need all these services. And these services are very costly. And you didn't factor into the cost for it. And they said, well, what are you talking about? 20 people, 30 people? We said, try thousands? And that's when they said, what do you mean? And we told them in LA County, the estimate at that time was 8,000 transgenders individual who wants to go and get this benefit done, right? Because it's their right. And we average out, if someone truly complete a transition, the cost is upward of over $100,000. And so if you multiply that by however many thousand individuals, just in Los Angeles alone, that's a lot of money, right? Number one. Number two, well, the regulation for a health plan is that if someone requests a procedure, you must make sure, or a service, you must make sure that that service is available within 14 days. That's a regular requirement, right? Well, there's not enough surgeons around to do that. And so we were violating it left and right? So we had to go out and recruit a surgeon. Believe it or not, there's a team of 2 of us at the health plan. We outreach to surgeons who we know, number one, have experience. Number one, that person must have experience and provide this kind of surgery. And number 2, would be willing to talk to us and probably get into a case agreement with us, right? And to provide these services. Because the rule is if you sign on as a Medicaid provider, then you have to make yourself available to anybody. And those surgeons said, well, I want to provide care for Medi-Cal people, but I only want to provide care for Medi-Cal people who enroll in LA Care, not other health plan. So I don't want to sign up to be a Medi-Cal provider because now I expose my practice to everybody else, right? And I didn't want that. But the state had the rule that you can't really have someone who you contract with for services who was not a Medi-Cal provider. They didn't register with the state. So we had to go up to the state and advocate and say, hey, there are so very few surgeons, and we found this surgeon in Los Angeles. I'm very proud to say that 2 of them are in Beverly Hills. Top surgeon, hot shot. It took me 6 months to appeal to them, and they finally said, yes, I would do it for LA Care. And so you got surgeon, we know the quality of their care, and granted that we have to pay them a bit more, and the state and our CFO okay, and the state okay, but this provider said they don't want to enroll in the network for Medi-Cal, because the minute they enroll, then they now have to take anybody. So somebody else belong to a different health plan, have a Medi-Cal card, knock on their door, and want services, and if they say no, they're in violation. So the state has to go through the lawyer and what have you, and finally said, okay, we're gonna make exception for you, and that's how we get around it, right? But it speaks to the access problem. For those of you who just came in earlier, I made a very clear point that just because people have an insurance card, it doesn't mean that they have access to care. That's what we're facing right now, and a lot of health plan is under the scrutiny of the federal government because, you know, if you enroll more people, you need to expand your network. But if there aren't that many providers participating in your network, then you now have a problem. Just imagine if a physician has 2,000 patients assigned to them, how would you ever get in to see them? Right? So network adequacy and access is a real issue that transcends policy. Is really, if anything, for let's say for straight people, access is even a problem because they're just not enough provider, right? So here is the updated cartoon map of which state participated in Medicaid expansion, right? So you can see those states in the deep south are really in trouble, but that means that those states, because of their own budget or because of their own legislature agreement, decided not to expand their Medicaid. Okay, so California expanded, but not all states expanded. Okay, and we talk about that. And you probably heard about the Supreme Court cases that went back and forth on some of the requirement on ACA, particularly one that prompted folks to want to repeal ACA is these notions of you must carry insurance. If you don't, then you have a penalty. Now, you don't have to raise your hand. I know in every single room, there's always half of the people who feel very differently. That buying an insurance is an individual right. Why would the federal government impose that on me? And that's the basis of the argument on why some people want to appeal part of the ACA. Okay? I can guarantee you there are people in this room who have that feeling. In fact, I have family members who have that feeling. So that's, I can tell you that. I have brothers-in-law and sisters who feel very strongly about that. That's very wrong. You have no right in imposing that on me. Okay? So it's very, very real. I mean, even in the, I have an LGBT friend who also feel that way. And to my disbelief, some of those friends really can't afford buying insurance themselves, but they have that very strong feeling. It's that core belief that get us into trouble, okay? But what it does is, at least in California, with the expansion of Medicaid and the exchange product, it brought out an insurance rate from 22% to 8%. So that's a huge improvement in terms of people having insurance. I'm not talking about people having access to care. Don't forget that piece. Because people just get on the bandwagon and say, oh, no, now people have access to care because of the expansion, because of ACA. That is absolutely not true. I'm not saying that because I want to repeal ACA. I'm the believer in ACA. Let me put that out there so you guys don't have a wrong idea about me. I'm 100%, 150% supporter of the ACA, but there are inherited problems that we as a community need to address. It is beyond policy, or maybe. So let me share this with you. How many of you in here are physicians again? Please raise your hand. Nobody yet, licensed physician. So I was one of those docs in California that was very controversial, and I brought this up with my local physician group. I won't tell you which county that is so I can stay out of trouble. I had this wild idea that in order for people to have a license to practice medicine, that including pharmacists, in this state, I think they have a legal obligation to at least provide care for the vulnerable. By that I mean they have to take certain percentage of individuals who are on Medi-Cal in their office. That's my belief. And if you don't want it, then you do not have the right to practice medicine in California. How many of you support that? Very good. Wait until you get your license and become a full-blown whatever. Let us have this conversation again. Because to my biggest surprise, I was in the minority. Many of my colleagues, gay or straight, have this inherited belief that nobody could tell me which patient I could see. Now for doc and pharmacists, all of you, when you wear your white coat, you had an oath in your school. And that oath said you are not supposed to deny care to anybody. Am I right? Remember that? John, remember that, John? I pick up John. Yeah, but to my biggest surprise, there are people who said, no, I don't want to take care of Medi-Cal people. Whatever reason, low payment, they dirty, they homeless, I don't want them in my office, etc. It is a real issue. To me, this access is not a policy issue, but is truly a moral, ethical issue for providers. Okay, let me repeat that. It is not a policy or financial issue, seriously. Some of you might disagree. Well, you know, I have hundreds of thousands of loans, especially if you go to medical school at USC. I need to pay my loan, and now you're telling me I have to take care of people who can't pay? I'm sorry, there's a reason why you went into medicine. And you choose to come to an expensive place. Maybe that didn't come out right. But you have a moral and ethical obligation, because when you sign on, when you wear that lab coat, you did make an oath to somebody that you take care for everyone. But now you choose not to because of financial reason. That's not okay with me. So I'm hoping that the California Medical Association will pick that up and run with it, because it will probably need legislative introductions in changing the licensing regulation in California. I really strongly believe in that. There are physicians who flat out say no. And not just physicians, therapists. Somebody said this, therapists. There are therapists here too. Believe it or not, in a majority of the areas in California, you can still practice as a therapist and be in a cash paying only situation. You don't need to participate in any insurance at all, and you're still full. And if you're really, really good, there'll be a line waiting outside your office. Am I right? For my therapist in the room? Yeah, I mean, you really don't need to participate. But now, here's the thing that you don't have to nod your head or shake your head. I believe that if you get a license to practice care in this state, you must participate in providing care for the poor. I'm sorry, that's how I feel. That's how I strongly feel. Now, you can walk out of this room now if you want to, it won't hurt my feelings, but you won't change my mind, because I truly believe that because of this access issue is really true. It's almost a crime to tell someone that, hey, you qualify for insurance, here's a plastic card, but I can't guarantee that you have any care and you can get any care. I think it's a crime. It's almost as if, hey, yeah, there's some rice. I'm Asian, so I have to talk about rice, right? Go past that. Here's a rice bowl, but sorry, we might not be able to fill it up with rice. That's just very wrong. Yes?
So it's not always just money that keeps physicians from participating. So we saw a
Very
phenomenon
hopeful.
in North Glendale, Pasadena,
Yeah.
when the ACA began,
Yeah.
that lots of physicians specifically and groups did not want to participate because they wanted Obama to fail and Obamacare to fail. And so the few practices that did happily participate got slammed. They got slammed. There was no sharing of access and patient care.
So I was waiting for somebody to tell me that clinicians are not practicing based on a political belief, but purely just religious belief, that now you know. Politics also drive how people make decisions, and it's absolutely true. One of the best hospital in town in LA. It's not Keck, so for those of you who are Keck students, don't worry, you're the best, but you're not the one I'm talking about. One of the best hospital in this county literally refused to participate in what we call the dual population, and it took us a long time to convince them. Okay, and one of the best educational system in this state now. Educational, healthcare educational system in the state, actually a public healthcare system in the state actually has no contract with Medi-Cal. Okay, that I have an ethical issue with. How could you, an institution, get taxpayer dollar to run your practice, but yet you refuse to have a contract with Medi-Cal? Thank God I'm not standing on that institution, because this is a private, nonprofit institution, not the one I'm talking about. So for those of you who are currently students in that institution, you really need to speak up and speak out, right? Yes, if you have Medi-Cal and you need tertiary care, you have no access to those institutions, because they just don't contract with Medi-Cal, period. Right? Something for you to think about, right? It's not always about religion. Let's see, so this slide talk about the individual mandates, what have you. The second bullet point, the sub-bullet point is very important, is that for states that expand Medi-Cal, actually there's many reasons for states to expand Medi-Cal, because the cost for this expansion population is actually not 50%. It's only up to 10% by 2020, right? So that's a whole lot of money coming from the federal government. But there are states, to your point, was not a blue state, and therefore they refused to participate in ACA and did not expand Medicaid to their poor population. That's what happened. Politics drive decision for healthcare. Okay? Medi-Cal expansion, we already talked about that. Currently, there's about 14 million Californians who's on Medi-Cal, which is close to a 50% increase compared to before 2014, right? And then roughly about another 4 million or so who's on the exchange product. So let me talk about, so here who's eligible in terms of government-funded program in California. This slide is very important. So not everybody qualifies for Medi-Cal, like I said, in terms of immigrants, right? For those of you who are not an immigrant, if you were born here, it's very easy, simple. If you're poor, you qualify. But for immigrants, it's a different story. There's other criteria. So you must have resided in the U.S. for at least 5 years in order for you to qualify, but if you're poor, right? If you're less than 5 years, and even though you qualify for Medi-Cal, you won't have it. You have to participate in the exchange product, meaning you have to still pay out of pocket. Okay, and we'll talk about the exchange product in a minute. Legal immigrant children and pregnant women, in 5 years waiting, you can have full scope of Medi-Cal. So this first group here, what it means is that first group, if you are a woman and children, or pregnant woman and children, then you would qualify for it. But for pregnant woman, you only qualify until you give birth and you have that Medi-Cal for about 1, 2, 3 months, and then that's it. It cuts off. Only the baby now qualifies for Medi-Cal. Does that make sense? Good answer. Good answer. Very good. It doesn't make sense, right? And then there are permanent resident under cover of the law could also have a full scope Medi-Cal if you are deemed disabled. Okay? And then in California, hallelujah, May 1st, 2016, individual 19 years old or younger get full scope Medi-Cal, who are undocumented, okay? Then the question is, why 19, not 18 and 21 or 26? I don't know. The legislature decided that that's a cutoff because of the cost. Okay? But technically, in California, under the health law, you are considered children, and under the healthcare coverage in this country, you are considered children and under coverage of your parents' insurance up to the age of 26. Okay? But this one cut off at 19, and even then, currently there are it was supposed to be for all undocumented immigrants, but then it was dwindled down to just for children, and then it went from 26 to 19. Okay? However, there's debate, and there is some proposal to cut this out completely, given the budget and given the change in the governorship in California. Okay, so please be aware and follow that. If you believe in it, I'm not going to force it on you if you don't believe in it. Okay. Here's the exchange. So if you not poor enough to qualify for Medi-Cal, but yet you can't really pay for your own insurance, I'm talking about people who have their own business that don't have coverage from an employer, then you can participate in what they call the exchange product. The exchange product is a government-supported insurance. So it depends on your income level and depends on which plan you want to participate in. A high premium, less copay, or low premium and high copay. So each level you can pick and buy the insurance, and then the government would supplement your payment. Okay, so that's the exchange product. Not all states in the union participate in the exchange product. Okay, the number of states that participate in the exchange product is even less than the number of states that participated in the Medicaid expansion. I want you to understand that. Okay, and so the hope was, well, maybe the young people who think that they're invincible and they really don't need to buy health insurance, and they rather pay the penalty every year at tax place, right? And believe it or not, there's a lot of what do we call it? I'm lacking for it. I'm sorry. This is Lunar New Year, and I've been having a lot of guests from out of town, out of the country, visiting that speaking different other languages that I completely forgot how to speak English. Folks who are entrepreneur, young people, especially in the Bay Area, startup, yes, and they make lots of money, the income is huge, but they don't believe in buying insurance because they think that they're invincible, right? I'm healthy, I don't have any illnesses, why would I need to buy insurance and pay every month premium? Because the penalty is actually much less. Honestly, it's about a few $100s a year if you don't buy insurance. But if you buy insurance, the premium is much higher, and people calculate and say, oh, then I ended up paying more, and I'm not utilizing insurance. Why would I buy? So there are still rich young people who don't buy insurance because of that. Okay. So the state exchange product, Exchange California, Cover California, is trying desperately to educate people that, yeah, physically you might be very healthy, you might not have diabetes, but nobody know when you get into a car accident, and folks was like, especially folk who live in San Francisco, I don't drive a car, so there's no need for accident, there's no way, right? And then we say, well, what about mental health? Nobody can predict when you have depression, anxiety, and coverage for that will be good. But that argument really doesn't work very well, because back to the point I made earlier, even if you buy insurance, you want mental health services, there aren't that many people participating in insurance, because therapists can just do well in the cash paying world. So that argument is not very, very strong. Okay? Financial help in the exchange, I'm not gonna bore you with that. Let's talk about healthcare for LGBT, that's why we're here. So the keynote speaker talked so much already, but this slide gives you the detail in what the health plan can and cannot do. as is related to health services and discrimination. And she's absolutely correct. Not all state in the union has federal and state level protection for sexual orientation or gender identity. Not all. Okay? But luckily in states like California and Washington, particularly entity like the Department of Managed Healthcare, which runs by lawyers hired by the state to advocate and protect individuals, they actually interpret the health law to the maximum. So people have a lot of protection in these states. Not the true doesn't hold for other states, as the speaker has talked about earlier. Here are some anti-discrimination law. The AMA, the American Medical Association, has adopted more than 25 rules and opinions calling for equal treatment of the LGBT community, and you can go on their website and download. But these are only adopted by AMA, but not all physician or health system follow it. Okay? So let me talk to you about my health system. So remember, for those of you who came in late, the speaker, I think, was kind of not unfairly, I don't think she intentionally did that, but that's probably because she didn't understand the Catholic health system. In the United States, the Catholic health system, or the Catholic decision, is governed by 33 archbishops and bishops of the Catholic Church. But the Catholic health system is actually an entity that comprises of multiple separate health systems. And most, I would say 90% of the health systems were actually started by the sisters, the Catholic sisters, not the priests. Okay, these were women that came from different part of the world and found themselves in the United States and developed these Catholic health system. So these are really powerful sisters. The one that I work for, Providence St. Joseph, the most impressive woman that you've ever met, strongly convicted in providing the care for the community, particularly the poor and the vulnerable. Particularly the poor and the vulnerable. And they themselves, they found themselves in a quandary now since 2014 because of the ACA expansion, because most Catholic systems do contract with the state entity to provide care for individuals with Medicaid. At least our hospital, under the regulation, we cannot turn away people due to their insurance, so we have to provide care. And when you have a contract with Medi-Cal or Medicaid, and it said specifically gender reassignment surgery is a benefit, there lies the problem in the Catholic religion. Because that's not something that you can do. So many sisters have gone up to the archbishop and the bishop, this entity, this body called ordinary. They call themselves ordinary. The one is making decision for the United States, for the Catholic system in the United States, and said, well, Father, what should we do? And the bishops and the archbishops in this entity said, absolutely cannot, because it goes against the Bible. And the sister said, but this is contractual agreement, we have to do it. We have a contract with Medicaid. And believe it or not, some of the bishops said, well, then don't contract. Okay? I have real problem with that. So I have constant conversation with the sister in my health system. And I was almost in tears when one of the sisters said, you know what, Dr. Chau? We have a history that we used to do first and ask for forgiveness later. And maybe we just do it, and if we get caught, then we'll deal with it later. That's progressive. That's really progressive. And it'll only take a woman to say that, not a man. I'm sure the priest won't say that at all, right? Because they have to respond to the Vatican, right? And these few particular women told me, sisters, I should say, sorry, I now have new meaning for the word sisters, said that, oh, we have a history of doing things, not asking for Vatican's blessing. Trust me, we have done that in the past. And said, way to go. So truly, it really isn't all Catholic that fighting and wanted to have these discriminative languages in our policy. Truly, there are really good people who really care. I was going to say don't care whether or not you're straight or gay, but they truly care for everybody. And these sisters said, I'm not the one to judge. All I see is these people are struggling and in pain, and if we provide health care, then we need to provide health care for all. So it's very interesting fight, I would say, because every year there's a Catholic health conference that thousands and thousands of healthcare workers in the Catholic health system convene, and this year that topic is going to come up, and there's going to be a huge debate. So I look forward to that. I was told that I will have to be at that conference to present, so wish me luck. I'm not a Catholic, by the way. So that includes sexual orientation, and which law exists that include protection for gender identity. Okay, this is California specific, so you can read that on your own. California AB 496 was introduced by Assemblyman Richard Gordon in Menlo Park in October 2014 that require healthcare providers to include LGBT-specific issues in the cultural competency training programs. So that was the first. And then Healthy People 2020 has made a set of recommendations specifically related to healthcare for the LGBT community. I've listed out for you to make it simple, but if you have trouble falling asleep and you want to help yourself at it, you can go online and find 2020, Healthy People 2020, a set of recommendations and read it. And the other way to help you fall asleep, very easy, is read that thousands and thousands of pages in the ACA healthcare law. And that's another good way to help you fall asleep as well. The Robert Wood Johnson Foundation study has funded a 2-year interdisciplinary analysis of health impacts on recent law, and they give the majority of the money to Vanderbilt University. The report should come out sometime mid of 2019, so I'm really looking forward to that. I'd have some really significant people in the area of law and economic to do this study, so that's very, very important. I think that would be a good basis for a lawyer to use as an argument for equal access to health. Yes, sir.
Dr. Chau, I don't mean to jump ahead on your presentation, but
Sure.
will you talk at all about piggybacking on the access and
Yes.
the lack thereof? Will you be talking at all about single payer, maybe especially SB 562 in the state of California, and how that impacts the gay and lesbian community, the LGBTQIA community?
So I didn't particularly put it in here because my health system is involved with that right now, and I can probably talk about it, but I would welcome your email. I'll go back to the first page. Please send me an email, and then I will discuss that with you, just because my health system is involved in it right now. So I apologize.
So is mine.
There we go. So we can have a sidebar conversation and not get in trouble, okay? So the statement that was made by the Trump administration on January 18 in 2018 is really, really important. And there's a lot of reason why that was brought up, okay? And some people argue that it really has nothing to do with the LGBT community. It has a lot to do with this whole notions of whether or not parents have a legal right to keep their children from being vaccinated. Remember that battle in California, particularly in California? And because parents and provider, doctor believe that if you expose children to vaccination, that they are at risk of not only developing autism, but there's some belief that that they are at risk of developing schizophrenia as well. And they are fighting to the teeth. And there are actually several primary care pediatricians in Orange County who wrote books particularly about this and spoke very openly about this issue. And the state of California trying to sue them and have not been successful based on their religious belief. Okay? So I don't know if you believe that. But I think what most important though, and she didn't mention this, don't know if she's aware, I'm going to send her an email, is the Center for Disease and Control and Prevention was given a list of 7 prohibited words or phrase by the Trump administration. So when they issue grant or regulation that's related to healthcare, these are the words that they are prohibited to use. Fetus, vulnerable, entitlement, diversity, evidence-based, science-based, and transgender. Do you see the impact on this? Because the CDC actually support a lot of research in terms of population health, particularly emerging epidemics. And if they are prohibited from using these words, you could see how much of an impact that would have on vulnerable population. That is even bigger than the creation of the division of conscience and religious freedom, in my opinion. Because the Trump administration can create that division, but not all people in the healthcare provider and the religious health system believe in it, right? But the bottom piece, the second piece, is important because that's part of the regulation. That means that you are not allowed to even propose that you want to work in these areas or an area where these 7 words are important to the population. That is huge. They kept it a secret, and only the Washington Post picked up and wrote a story about it, but it has not spread nationwide yet. There was in the research area, we became alarmed. And I think the CDC is fighting back, of course, but they are preparing a letter to send it out to all the folks who are receiving funding from the CDC. This is not just research funding, but also care funding as well. So a lot of public health departments do receive funding from the CDC to provide care. So this is important. I really urge you to call your local senator, really tell them to do something about it and to bring that up at the Congress floor, because this hugely affects a lot of people, particularly the LGBT, right? Particularly the transgender community. Okay? So an insurance card alone does not guarantee access to quality care. This is the point I want to share across, because there is, and here are some references for some of those regulation and rules pertaining to the LGBT community. But there aren't that many, as the keynote speaker pointed out. There aren't 1/3. That means we are clearly not a very rich state that people think we are. Okay? The county of Los Angeles, despite we have Malibu and Beverly Hills and what have you, more than 1/3 of the residents in this county are on Medi-Cal. Okay, and there are county like Kern County, they have a half of their population on Medi-Cal, and some remote county almost have 60 to 70% of their residents on Medi-Cal. But so we are not a very rich state. Okay. So which means if the federal government said, we're not gonna send you your portion of funding, we're in big trouble. I just told you with the expansion, we brought in 8 million people in this state into the Medi-Cal world, and the federal government pays for more than 90% of those costs. More than 90% of those costs. So if something happened, we'll lose it, okay? So one of the new things that's gonna come out, and it's gonna take a whole lot more community involvement in driving this, and that is the decision the federal government made that state now have the right to require Medi-Cal enrollee to pay for copay in the treatment. Before the Medi-Cal expansion in 2013, the state of California, that set of legislature at that time in Sacramento, submitted an application to the federal government, in this case the Center for Medicare and Medicaid Services, and requesting for California to put into regulation that it would require people on Medi-Cal to pay for copay, because right now if you're on Medi-Cal, there's no copay, nothing at all. It's completely 100% free. So the legislature at that time submitted an application for California to charge people a minimum amount of fee. I remember, like, for a doctor visit, a primary care doctor visit is $5, specialist is $10, which is still less than most of private insurance. And then for prescription, something like $1 copay. And the CMS at that time said, no, absolutely not. You cannot do that. But currently, the federal government said yes, and the first state submitted that, a request is Kentucky, and it's just got approved. There are languages being drafted now by the California legislature in Sacramento to reapply for that condition here in California. And I believe the proposal is that a primary care visit is $10, inappropriate emergency room visit, I want to say, inappropriate emergency room visit is $50. Because, like I said, not people's fault, to most of the health plan surprise, even when people are giving Medi-Cal card, they still utilizing the emergency rooms as a point of care, right? And health plans got very upset because it's much more expensive than if they utilize primary care services. And I was the first one, went up to the state and said, what made you think that people who had no insurance for a majority of their life, and the only place that they could get care before 2014 was the emergency room? And now suddenly you give them a card that it would change their behavior. Number one. Number two, the real key issue is you have to look at your network adequacy. Remember? Now I get a card and you assign me to a doctor, but this doctor also has 2,000-3,000 other patients that they have to see. When do I get in? So that's an access issue. And if you are someone from the LGBT community, well, you're assigned to me to a doctor that have absolutely no clue on how to treat me, especially individuals from the transgender community. Yes, sir.
Well, one thing that was not touched this morning, opening the draft, and one thing that you're not touching right now, just kind of a roundabout thing,
Yes.
is SB 496 on cultural competency. I've encountered many healthcare providers that have not provided that for staff whatsoever, and physicians.
Yeah, so the remember the one that I referred to? That is only for CME program to establish cultural competency training. So if you want to get CME credit, at least for CME only, continuing medical education, and in order for you to get the credit, the organizer of that CME course have to wrap in cultural competency, number one, number two, and have to mention LGBT. But the regulation is very lax. You can just put one sentence on the slide that said LGBT, and the speaker never ever have to say it, and it would qualify. That's the problem. That's the problem. So what happened is, I'm a CME provider, right? I give out the credit. You as a speaker come to me, propose the topic, and you have to submit a slide deck. I think that's the same thing that John and his colleague did for this CME track. And the CME provider have to read the PowerPoint presentation, have to ensure that the topic is relevant, of course. And number two, that somewhere in that slide deck, you have to mention cultural competency, different ethnic and cultural group, and particularly you have to mention LGBT. All right? Will all CME provider read every single slide deck that slide across their desk? They're supposed to, but many of them don't. Number one. Number two, how often would the CME at the state level, in this case, IMQ, Institute for Medical Quality, would regulate and audit the CME provider to make sure that every single PowerPoint has this piece in there? Every 3 years is the audit process. Well, would they read every single CME application and every slide PowerPoint presentation? No, they don't. So that's the issue with that. So unless somebody like you said, hey, I went to Dr. Chau's presentation, he didn't say anything about LGBT at all. So I'm gonna raise that issue with the CME organizer, John, and whoever give him that credit, I'm gonna raise that issue with them. Would they respond? Most likely they'll send you an email saying we apologize for the inconvenience or the what have you. Here's the new slide deck, so they slap that sentence on it and then resend it out to you, and that will be okay. It's a huge issue, right? So there are rule and regulation try to make it, but whether or not you would reinforce it is a different story. Off topic a little bit, but here's something really important too that we ought need to know is happening in California right now. How many of you are aware of the case of the 19-year-old Orange County resident that got killed by his former classmate?
Please.
Huh?
Please, for instance.
Yes. So, did you know that if the city, the DA office, decided to go for a hate crime, it would lessen the severity? Did you know that? There's no protection. And if they decided, which the DA would not most likely go in that route, but I hate to use this term, the killer's family is trying to advocate for the DA to go the hate crime route because it would carry lower penalty, right? Did you know that in a murder charge, there is a special circumstances laws that if it is argued against, then it will bring severe punishment on top of it, okay? That special case, that special amendment, or whatever the language they use, does not include sexual orientation and gender identity, okay? So Senator Janet Nguyen recently just introduced SB 971, so please write that down, SB 971. Wanted to include sexual orientation and gender identity in view of all the transgender that got murdered across the nation, particularly high number in California in 2017. She wants to introduce language around sexual orientation in those special circumstances so that it would carry a higher punishment, life imprisonment in California. Okay, because if you don't do, currently the law doesn't have it, and the lawyer, the defendant could go and argue, and he could get off with a lesser sentence. So we need to, you all need to call, if you believe in it, of course, you need to call your local senator and assemblyman at the state level and advocate and ask them to pass SB 971 particularly. And it's really crucial because he's going to court hearing sometime this summer. And he could get away from it, okay? That's an example of, yes, there are some law, some regulation, but there is no specific language speak to sexual orientation and gender identity. And therefore, things like this people get away with murder, no pun intended. Okay? So that protection under sex is very general, and it could be argued both ways, and she eloquently said, most of the time, the community loses. Right? Time's up? Oh, wait then. Time's allowed. So I'll stick around if you want to come up and talk. And definitely, please write down my email address, and then I'd be happy to start a conversation with you.
Great. Thank you, Dr. Chau, for joining us.